Bismillahirrahmanirrahim. The next topic of our discussion is liver cirrhosis. So, liver cirrhosis is an end-stage liver disease which is characterized by fibrosis, formation of parenchymal nodules, and loss of normal architecture of liver. So, liver cirrhosis is an outcome of chronic liver disease. The most common cause of liver cirrhosis is hepatitis B virus infection followed by hepatitis C. A growing cause of liver cirrhosis is alcoholic fatty liver disease. Other causes of liver cirrhosis include certain drugs such as NSAIDs, alpha-methyl dopa, which is used as an antihypertensive agent in pregnancy, and isoniazid, which is used in tuberculosis treatment. Moreover, autoimmune hepatitis also progresses to liver cirrhosis, and certain metabolic diseases such as hemochromatosis, alpha-1 antitrypsin deficiency, and Wilson's disease may often progress to chronic liver disease and ultimately liver cirrhosis. In certain cases, when cause of liver cirrhosis is unknown, it is known as cryptogenic liver cirrhosis. So liver cirrhosis occurs as a result of chronic inflammation, which is driven by production of certain inflammatory mediators. So these mediators result in the activation of stellate cells, which then transform into myofibroblasts. So these myofibroblasts increase the deposition of type 1 and type 3 collagen in the liver, resulting in fibrosis. The pathogenesis of liver cirrhosis is divided into two phases. The first is initiation, which is followed by perpetuation. So in the initial phase, there is damage to hepatocytes and activation of Kupffer cells. What are the Kupffer cells? Kupffer cells are inhabitant macrophages of liver. So what happens is the injured hepatocytes and Kupffer cells release certain growth factors such as IGF, tissue growth factors, and platelet-derived growth factors. All these growth factors result in activation of stellate cells, and the activated stellate cells result in deposition of type 1 and type 3 collagen, resulting in fibrosis in the liver. Moreover, activated stellate cells also inhibit matrix metalloproteinases by secretion of TIMP1 and 2. Hence, there is increased matrix degeneration, and certain chemotactic factors result in recruitment of additional leukocytes. Endothelin 1 results in sinusoidal constriction, resulting in portal hypertension. So by far, production of these inflammatory mediators and growth factors result in fibrosis. So these tissue growth factor and platelet-derived growth factors also result in neovascularization and increased proliferation of hepatocytes, resulting in formation of nodules. So extensive presence of fibrosis and proliferation of stem cell hepatocytes ultimately results in loss of normal architecture of the liver. The chronic cycle of injury and healing result in the activation of Kupffer cells, which result in fibrosis and formation of nodules in the liver. The cirrhosed liver is incapable of performing its normal usual functions, hence the disease resulting is known as decompensated liver disease or DCLD. The gross appearance of a cirrhosed liver reveals multiple nodules. So on basis of the morphology of these nodules, a cirrhotic liver may be micronodular, macronodular, or mixed nodular. So in micronodular cirrhotic liver, the size of nodules is typically less than 3 millimeters. Whereas in macronodular cirrhotic liver, the size of nodules is greater than 3 millimeters. In the mixed nodular liver, there is presence of both micro and macronodules. Due to loss of normal architecture, the liver appears to be shrunken and there is formation of fibrous septa. The cut section also reveals multiple nodules which are separated by fibrosis. The histological picture reveals loss of normal architecture of liver and there is fibrous septa. This fibrous septa can either be bridging or it could be non-bridging. The bridging could be between two portal tracts, or it could be between a portal tract and central vein. So let's say these are the portal triads and this here is a central vein. So let's say this is the fibrosis around portal tracts. So bridging could be either between the two portal tracts or it could be between a portal tract and central vein. So this is the bridge between a portal tract and a central vein, and this is the bridge between two portal tracts. Whereas you can see here, there is no bridging present in fibrosis around this particular portal tract. Hence it is known as non-bridging fibrous septa. The histological picture also reveals presence of certain leukocytes such as macrophages, plasma cells and activated stellate cells. The activated stellate cells are the main culprit in fibrosis, which is accomplished by deposition of type 1 and type 3 collagen. Type 4 collagen is already present inside the normal liver. There is also proliferation of hepatocyte stem cells resulting in formation of nodules. And there are focal necrotic areas as well due to chronic inflammation. Mitotic bodies are frequently seen in the hepatocyte stem cells. So liver cirrhosis is divided into further stages on basis of degree of fibrosis and formation of nodules. So in stage 1 there is fibrosis around few portal tracts, not all but few portal tracts. So in stage 2 most of the portal tracts are fibrosed. In stage 3, in addition to the fibrosis of most portal tracts, there is little bridging as well, but the bridging is actually incomplete. It means that the bridges are actually extending, but these are not completely cross-linked. In stage 4, there is occasional bridging between two portal triads, whereas in stage 5, there is extensive bridging between portal tracts as well as between portal tracts and central vein. And in addition, there is formation of few nodules. The last stage is stage 6, which is characterized by complete liver cirrhosis. So in this case, there is extensive fibrosis of portal tracts, there is multiple bridging, and there is presence of multiple nodules. Liver cirrhosis is mostly as a result of a chronic liver disease. Most cases have a history of hepatitis B or hepatitis C virus infections, whereas it is also common in chronic alcoholic disease. The non-specific symptoms of chronic liver disease and liver cirrhosis is nausea, vomiting, and abdominal pain. The abdominal pain is mostly in right hypochondrium. There is jaundice, which is characterized by yellow discoloration of sclera, skin, and mucous membranes. Jaundice becomes evident when serum bilirubin level is more than 2 to 3 milligrams per deciliter. Moreover, there is portal hypertension, which is characterized by presence of ascites. Ascites is presence of fluid more than 500 ml in peritoneum. This causes eversion of umbilicus and there is specific fluid thrill on percussion. Hepatic encephalopathy is characterized by confusion and stupor, which can also progress to loss of consciousness and deep coma. Coagulopathy is often present due to lack of formation of clotting factors, and variceal bleeds are common in cases of portal hypertension. Since there is opening of portosystemic shunts, variceal bleeds are often seen in the patients with chronic liver disease. The most common sites of variceal bleed is gastroesophageal junction, which results in hematemesis or blood vomiting. The other site of variceal bleed is rectum, which results in bleeding per rectum. Hematemesis is more dangerous and it constitutes a clinical emergency. The bleeding vessel needs immediate ligation. The abdominal examination also reveals formation of a specific spider-like dilation of veins, which is known as caput medusa, or they may also be known as spider angiomas. These spider angiomas are actually subcutaneous abdominal veins dilation. In liver cirrhosis, there is decreased metabolism, so there is a decreased metabolism of estrogen as well, which results in increased estrogen levels, which lead to gynecomastia, palmar erythema, and hot flashes. Moreover, there is hypoalbuminemia in the blood as well, which results in increased fluid shift into third space, resulting in edema. The only treatment for liver cirrhosis is liver transplant. So this concludes our discussion about liver cirrhosis. If you have any questions, do let us know in the comment section. Thank you.